My name is Iman Chaudhry. I'm working with Danielle Lewis and Oliver Cerquiera from the Department of Internal Medicine at the OUTU School of Community Medicine. Our case report is titled Nasty Nivolumab, a case of a rare skin finding. Novel immunotherapies that treat malignancies can cause many different side effects, including dermatological reactions. Bullous pemphigoid is an uncommon skin condition. It presents with thin-walled, tense, fluid-filled blisters. These blisters can be found on any part of the skin, but are often found on the extremities, the groin, and the axilla. In rare cases, they can be seen on mucosal surfaces such as the oral mucosa, eyes, and the esophagus. The following is a case report on a patient who developed bullous pemphigoid lesions secondary to his chemotherapy agent, Nivolumab. Our patient is an 82-year-old male. He came in with past medical history of COPD, hypertension, lung adenocarcinoma with mets to the bone, actively being treated with Nivolumab or Opdivo, which had been initiated in February of 2020, and tobacco use disorder. His chief complaint was a rash which began about a year ago and had progressed in the past 2 months with significant worsening over the past week. This rash began on the palms and the dorsal surfaces of his hands bilaterally, spread to his extremities, his oral cavity, anterior and posterior thorax, and finally to the abdomen, buttocks, and legs. He characterized these lesions as itchy and painful with friction. He denied any recent illnesses, new medications, skin trauma, or exposures to insects or animals. He had recently been evaluated by a dermatologist who prescribed oral steroids which slightly improved the lesions. The dermatologist, however, was concerned that the rash might be something more serious, such as Stevens-Johnson syndrome, so the patient was transferred to the hospital for a higher level of care. Labs revealed a low white count of 8.5, RBCs of 3.4, hemoglobin was low at 9.6 with an MCV of 88, and CRP and ESR were both elevated at 4.6 and 34. On exam, the patient's lesions were round erythematous and both target-shaped papules as well as bulla, ranging from 1 to 5 centimeters in size. These lesions were located on the palm, the axillary region, shoulders, oral right pharyngeal arch mucosa, right upper thorax, the buttocks, and the right anterior thigh. These skin lesions were cultured and demonstrated normal skin flora. Here's a picture of our patient's anterior right thigh. You can see a couple of the tense, fluid-filled blisters. Due to concerns that our patient may have bullous erythema multiforme secondary to HSV, we started the patient on IV Solumedrol, diphenhydramine, and acyclovir. We did serology testing for various viruses, including CMV and EBV, but no active infections were noted. We also checked the patient for paraneoplastic antibodies, but these had not resulted during the hospital stay. We finally biopsied one of these lesions. The pathology results came back positive for bullous pemphigoid. Based on the patient's medical history and symptom timeline, we suspected the patient's bullous pemphigoid rash was secondary to his chemotherapy agent, the Nivolumab, a rare cause of bullous pemphigoid. Our patient was discharged on a tapered prednisone regimen. He was also discharged with instructions to apply a high-potency topical steroid cream on these lesions. He was set up outpatient to follow up with his oncologist as well. There are a couple of important discussion points to be noted from this case. PD-L1 inhibitors, such as Nivolumab, can induce bullous pemphigoids in rare situations. It's a rare but serious complication of these chemotherapy agents, even in patients who have been on these treatments for a long time. Patients with such reactions require quick recognition and treatment with systemic and topical steroids.